Hey guys, thanks for clicking in. This is Dr. Linville. This is part one of a two-part series on elbow differential diagnosis. It's one of my favorite topics of the whole year. If you have questions, please do not hesitate to email or get in touch with me. So without further ado, let's get into elbow differential diagnosis and treatment part one. Objectives: we want to apply and integrate the basic science and clinical concepts learned in previous courses to the clinical topics studied in this course. Want to understand and integrate the components of the 5 elements of patient and client management in a manner that will optimize patient outcomes. This includes your exam, your eval, diagnosis, prognosis, and intervention. We want to synthesize, categorize, and evaluate information collected from an initial exam to develop a clinical diagnosis, while representing the impact of a condition on the function at the level of the system, the whole person, and the person's participation in life. We want to determine an accurate patient prognosis from a diagnosis and develop an appropriate plan of care grounded in evidence-based concepts in order to optimize outcomes. And finally, we want to determine appropriate interventions for diagnoses discussed throughout the stages of healing. So lecture lab information, all of this should be no surprise to you. I want you to please review anatomy of the elbow in depth prior to our lecture and lab. You are expected to know the following: the arthro and osteokinematics of the elbow, open, closed, packed positions, and the presentation of an asymptomatic or normal elbow. Special tests will be covered in lab, and video demonstrations will hopefully be uploaded to your YouTube channel and or the course shell. Speaking of that, I will also, I'm hoping to have a video lecture regarding the interventions of the elbow and some techniques you can use for your final practical exam as well. So how we break this down is we look at practice patterns, and the first one we'll look at is practice pattern 4D, and that includes impaired joint mobility, motor function, muscle performance, and range of motion associated with the key phrase here, connective tissue dysfunction. So, of course, connective tissue can be anything from bone to fascia to skin, all of these things. So, cartilage. We will go over all of these connective tissue dysfunction medical diagnoses as you see below. That includes arthritis, osteochondritis dissecans, or we would call that OCD, of the capitulum. We'll also look at radiocapitellar chondromalacia, posterior elbow impingement, and then finally the big dogs of this lecture is elbow instability or ligamentous injuries. Those include your ulnar collateral ligament or UCL sprain and the lateral collateral ligament. We'll also touch on little league elbow, which is a growth plate disorder, and in this lecture we will go over both conservative and surgical interventions and some treatment ideas for each of the following. So without further ado, let's get into it. Elbow osteoarthritis, or OA. This usually occurs secondary to trauma, history of instability, repetitive stress, or other medical conditions, including rheumatoid arthritis. Osteoarthritis usually affects weight-bearing joints, making the elbow one of the least common areas for OA. Patient may complain of diffuse pain and loss in range of motion. They may state a grating or locking sensation in the elbow, and they might have diffuse joint swelling, which may lead to numbness and tingling in the hand, and this is secondary to nerve entrapment, just due to the increased intercompartmental space. Treatments include, of course, both conservative and surgical treatment, but conservative treatment could include physical therapy, but it also might include corticosteroid injections for pain management, and then viscosupplementation for improving joint sliding. All right. Viscosupplementation can be seen in the picture in the top right. You'll notice they're injecting this fluid into this patient's elbow. And then surgical treatment, you can either have an arthroscopy for loose body removal or joint resurfacing, or an arthroplasty, just like we would in the hip or the knee. An arthroplasty is just a joint replacement, so you can have this, some people might call it total elbow replacement. You can see this artist's rendition of an osteophyte formation and cartilage damage on the bottom right. That patient may be indicated for an elbow replacement. So here are 2 radiographs. The normal elbow radiograph is pictured on the left, and you'll notice that there's normal joint space and what we would consider clean anatomy. There's no fractures, there's no osteophytes, there's nice soft tissue contours. It looks like a young, healthy person. And then if we look at the picture on the right, you'll notice that this is an elbow with osteoarthritis. There's decreased joint space and there's osteophyte formation. You can also tell through the soft tissue contours that this patient may be older. This is a patient that may, if this condition worsens, might need an elbow replacement. And that looks like this. So the picture on the left is a radiograph of a patient I've had with a total elbow replacement. What you'll notice is that there's also these little metal staples on the x-ray around the back side of the elbow, and that's just where the surgical site is cut, and then they staple it together, staple the skin back together. What you'll notice in this elbow replacement is there's two stems associated with it. One stem goes up the shaft of the humerus and the other down the shaft of the ulna. They try to salvage as much of the capitulum and the radial head as they can. They can also perform a radial head arthroplasty, and that's maybe for a different time. We'll discuss that, but essentially they're just trying to reestablish the hinge joint in this patient. So moving on to our next diagnoses, osteochondritis dissecans of the capitulum. If we know our review of anatomy, the capitulum is at the distal end of the humerus, and it articulates with the radial head, the fovea of the radial head. So the background information here typically occurs in adolescent athletes, throwers, gymnasts, swimmers, tennis players, etc. So upper extremity youth athletes. I also want you guys to look up Panner's disease. If you don't know what that is already, I encourage you to look that up because these are very similar. The mechanism of injury is not well understood, but we know it's due probably to a focal artery injury to the cartilage and subsequent bone necrosis resulting from lateral radiohumeral compressive forces. This is likely due to an increased valgus stress and repetition, like throwing. It also could be due to increased weight bearing through the elbow, as seen in gymnasts. This may include a past medical history of radiocapitular chondromalacia, which typically seems to come first, and we will dive into this in the next several slides. Your patient will probably state that they have an insidious onset of diffuse lateral elbow pain. They have a decrease in elbow range of motion, and they have pain at the radiocapitular joint, which is increased with active or resisted pronation and supination. And I want you to think why that is. May complain of locking, catching, and clicking. So how do they diagnose this? Well, they usually do it through X-ray or MRI. If we notice the radiographs on the right, you can see that, and the bottom is a CT scan, I believe. So if you look at the pictures on the right, you'll notice that the capitulum seems to have a divot taken out of it, and that's just a loss of cartilage in that area. And that's what OCD is. Treatments, again, both conservative and surgical treatment. For conservative treatment, physical therapy works very well for these patients. You want to discontinue aggravating activities for around 3 to 4 months, try to allow that area to heal. For physical therapists, we want to focus on thoracic spine mobility, scapular stabilization exercises, glenohumeral joint mobility, periscapular and rotator cuff strengthening, and non-painful elbow mobility and strengthening exercises. You are allowed to perform joint mobilizations, but they need to be pain-free. If your patient is having pain with joint mobilizations, you are likely increasing the compressive force through the lateral compartment of the elbow and are likely making things worse. Surgical treatment works best for stable lesions. That's a lesion that is not forming any loose bodies and that might be smaller in size. An unstable lesion, what they would do is they'd go in and they would debride it. So debridement, loose body removal if there's any loose bodies of cartilage floating around, and they may do marrow stimulation, which some people might refer to as microfracture. But the best treatment for unstable lesions has been suggested to be OATS. And OATS is osteochondral autologous transfer system. So if we break that down, osteochondral, so we're taking cartilage and bone, autologous, meaning from yourself, and transferring it to another part of the body. So OATS, there's been superior results in the knee over microfracture procedures, which microfracture includes the surgeon drilling or picking small holes into the osteochondral bone to elicit increased blood flow to try to improve healing. What we know is that in knees, there's an 87.5% survival rate in those patients with OATS, and that means the cartilage has actually held up and survived after being transferred to a new area at 8 years. The donor site is typically a non-weight-bearing portion of the lateral femoral condyle of the knee. There's been several studies in good journals like the Journal of Bone and Joint Surgery and the American Journal of Sports Medicine that suggest that 90% healing rates, excellent function, and high return to sports in these patients. So if we look at the picture on the left, you'll notice picture A and B. Those are radiographs of pre- and post-operative OATS. You'll notice that the capitulum on picture A has that quote-unquote divot or cartilage damage, and then picture B is where the bone plug has been placed. If you want to see what the surgeon's view, you'll notice that picture C, D, E, and F is showing you this. So they first drill a hole into the lesion to try to make a site for the donor graft. They then excise a donor graft, usually from that lateral femoral condyle of the knee, and then they plug it in using this pink tamp. So they just tamp it in and try to make it flush with the joint surface there. And if it's a large lesion, they might use multiple plugs, which is pictured in picture F here. In the elbow, this is a much smaller area, so you might only have room for one plug. But the goal is to improve the congruency of the cartilage. So now let's get into radiocapitular chondromalacia. And through your medical terminology, you should know that malacia stands for or means softening of something, and usually it's in regards to cartilage. So chondromalacia, it's almost the first sign of injury to cartilage. Background information: this is cartilage irritation and or damage at the radiocapitular joint. Progression of symptoms may lead to OCD, as we just went over. Is typically seen in adolescent athletes, throwers, gymnasts, and swimmers, a very, very similar patient population to OCD. Again, the mechanism of injury is repetitive valgus stress, causing compressive forces in the lateral elbow. Patient's history, signs, and symptoms is very similar to OCD. Clicking, catching, popping, and locking. This is not a dance move, but this is something all your elbow patients might complain of. Are clicking, catching, popping, locking, catching. I said that. Lateral elbow pain with active movements of the elbow. Swelling and localized tenderness may be present, and they may experience numbness and tingling when symptoms are aggravated with movement or examination. Treatments, again, both conservative and surgical. Conservative treatment includes similar treatments as OCD, so I encourage you to review that. The PT, again, is going to focus on T-spine mobility, scapular mobilizations, the shoulder joint, periscapular and rotator cuff strengthening, and non-painful elbow drills. Again, joint mobilizations as long as they're pain-free. And then the big thing here is you want to assess throwing mechanics in the kinetic chain. So a lot of kids are really learning what their motor patterns are, and we can really help them in this area to decrease stress on the elbow. And then surgical treatment is not really indicated unless this condition worsens to OCD or there are loose bodies present. So now let's move into elbow instability or ligamentous injuries. This is the big dog of all of the ones of this lecture. The ulnar or medial collateral ligament sprain. We would just refer to this as a UCL sprain. Background info. Injury to the major stabilizer of the medial elbow. The UCL is comprised of three bands, the anterior, posterior, and transverse. In the elbow, bony anatomy provides the primary stability at less than 20 degrees of elbow flexion and greater than 120 degrees of flexion. So there's this arc from 20 to 120 degrees where the primary restraint and dynamic stability comes from the UCL. This is the most important portion of this slide, is that the range from 20 to 120 degrees is the arc of motion where overhead throwing occurs, which is why the UCL is at increased risk for injury in throwing athletes. The mechanism of injury is repetitive valgus overload, throwing, or trauma causing an acute valgus stress. Patient history, signs, and symptoms. They will report of medial elbow pain, pain during throwing, pain, laxity, and gapping with valgus stress test, and they may report a history of a pop or numbness tingling into the hand, and that's usually secondary to inflammation in that medial compartment of the joint, which then compresses the ulnar nerve, giving them symptoms distally. So we will go more into special tests in a later slide, but special tests include the following: palpation to the sublime tubercle or the mid-substance ulnar collateral ligament, valgus stress test, which you guys should know, 0 degrees and between 20 and 30 degrees. We'll also go over the milking maneuver and the valgus extension overload test, aka the moving valgus stress test, which you see in the picture below, which was first described by O'Driscoll. It's essentially a shear test to the elbow. Of the 3 ligaments making up the UCL complex, instead of ligaments there, we should put that of the 3 bundles making up the UCL complex, only the anterior bundle provides significant restraint to valgus force of the elbow from 30 to 120 degrees. This was seen in a study by Dugas. So that is an important point. So ulnar collateral ligament reconstruction, this is also known as Tommy John surgery. How do we diagnose that the UCL is even torn? Well, we have to do it through MRI, and it's usually with injected dye. So the picture on the right is an MRI with an injected dye, so we can see where inflammation is. And there was a term coined by Dr. James Andrews, who is a well-renowned orthopedic surgeon. He has coined this the T sign. So that's when you see this dye in the joint line, and then over in the medial elbow that spans both proximally and distally. So if you flip that picture on its side, that would look like the letter T. And that's a good indication that there's likely a tear in the UCL. Conservative treatments, they have been affected with low-grade partial tears, but when high-grade or complete injury are apparent, the probability of return to sports is very low, just because there's no stability in the elbow. Reddig et al. Reported on the non-operative treatment of throwing athletes. So these patients had just conservative treatment of physical therapy. 42% returned to previous level of competition at an average of 24.5 weeks. So we're talking 6 months, only 40% returned. I don't think that's a great outcome. Treatments include rest, anti-inflammatory modalities, possible bracing or splinting, and of course physical therapy. There is also PRP injections that have been proven to be successful, and I've seen several of those, so we can talk about that outside of this lecture. Surgical treatment, of course, includes the UCL reconstruction or repair. The difference between a reconstruction and repair is a reconstruction reconstructs the ligament using a graft. So it could be an autograft, which is taking tendon or ligament from your own body and putting it in a new spot, or from an allograft, which is from a cadaver. And a repair is when they try to just, without trying to use the word in the definition, a repair is when they use your own tissue or the tissue that was injured and try to suture it together or repair that tissue. So typically what happens is they do a combination of both, where they'll try to salvage as much of the normal UCL as possible and then reconstruct it using a ligamentous autograft. There are several different techniques to this surgery, so please read the Dugas article. It will be uploaded. You are expected to know a few of the techniques in this surgery. Little league elbow, is also known as medial epicondylar apophysitis, is a term used to encompass most of the medial elbow problems reported by youth and adolescent athletes. The medial epicondylar apophysitis is a common pathology related to repetitive valgus stress at the elbow in youth throwers. The incidence of a little league elbow in early adolescence has been reported to be from anywhere from 4 to 40%. The spectrum of pathology at the medial epicondyle can vary from irritation to the origin of the flexor pronator mass through fragmentation and avulsion of the medial epicondyle. And this is due secondary to weakness in the growth plate at the medial epicondyle. So in youth athletes, the area of least resistance, or the weaker area, is the growth plate, and the UCL is actually very strong in comparison. So instead of tearing their UCL, they usually injure the growth plate. And we'll have a slide that goes over this a little better picture here. The mechanism of injury is repetitive throwing before growth plates fully fuse, and the patient history is typically between 8 and 11 years old, so a little younger than the teenage athlete. And we will look at the subjective risk factors on the next slide. All of this information is taken from Dr. Ellen Shanley and Chuck Thigpen, who have done tremendous research in the area of youth throwing injuries in both baseball and softball players. Patient history, signs, and symptoms. The same history as a UCL sprain, but in youth athletes. Each of the following factors alone or in combination increase a player's risk for serious elbow injuries. High risk factors include rapid growth in size and or throwing velocity, asymmetrical loss of internal rotation at the shoulder, and actually the newer studies are now showing that it's an asymmetrical loss of both internal rotation of the shoulder and horizontal adduction. And what they're thinking is this is posterior joint capsule tightness and posterior muscle stiffness of the shoulder. Scapular dyskinesis is also a risk factor, decreased kinetic chain activation and control, and decreased coordination and neuromuscular control. Those are your personal risk factors, but there's also risk factors in your competition or how you play the sports. So this is specifically looking at baseball, but catching, pitching, or playing both catcher and pitcher is a risk factor. Playing on multiple teams and leagues in 1 year. If you have an aggregate pitch count over 80 pitches per game, or you participate in your throwing activity during at least 8 months out of the year. If you throw the slider pitch tight, if you pitched with arm fatigue, and if you pitch with improper mechanics. All of those are great test questions. So here's what I wanted to show you guys earlier when we talk about the medial epicondyle avulsion fracture. So if we first look at the picture on the right, you'll notice that this youth athlete has an avulsion of the medial epicondyle. And this is due to repetitive valgus overload and stress. So what would they do? And this is a tragedy for any youth athlete, is for the medial epicondyle to be fixated using a screw, as you see in the picture. Now that will reestablish the bony congruency. However, there's many complications that might come with this, especially if this patient wants to be a high level baseball player or softball player. If you look at the picture on the left, you'll notice the different compressive and tensile forces during throwing. So the blue areas represent where growth plates are, your medial and lateral epicondyle, and then also just distally to the radial head, or we would call that like the radial neck. So if there's tensile forces on the medial side, you can see how the radiocapitular joint would compress, and they use this nice red like explosion image of the the compressive forces here, which also, if you go back in the lecture here, will eventually lead to radiocapitular chondromalacia and then maybe OCD of the capitulum. So you can see how all three of these are related, and usually the sequence of events is UCL injury or medial apophysitis here. which then leads to instability of the medial elbow, which then increases compressive forces on the lateral elbow, which may lead to that radiocapitular chondromalacia or the OCD lesions. I hope you're starting to picture how all of this comes together. So what treatments can we do? Typically in these patients, surgery is not indicated. Obviously, if the medial epicondyle is avulsed, then we're talking surgery. But typically, these are just stress-related irritations to the medial epicondyle growth plate. So what do we do to help? Well, you'll notice the picture in the top right. This is Dr. Ryan Geary. He is a colleague of Dr. Shanley and Dr. Thigpen. He's demonstrating two different stretches, the sleeper stretch and then the side-lying crossbody stretch. This is to address the posterior capsule of the shoulder and also the tightness and the stiffness in the posterior shoulder musculature. That is a huge risk factor for increasing elbow stress if those areas are tight. So conservative treatment includes discontinuing aggravating activities. That's an obvious one. And then physical therapist, much like our other treatments so far, you're going to address the whole athlete: thoracic spine mobility, scapular stabilization, glenohumeral joint mobility, and shoulder girdle flexibility as pictured on the right, periscapular and rotator cuff strengthening, and non-painful elbow mobility and strengthening drills. You also can start working on throwing mechanics, and I routinely in the clinic have patients go through their lower body throwing mechanics while they'll have their arm kind of tucked into their side, so they're not going through the throwing motion, but they're going through the overall kinetic chain from the foot all the way up through the thoracic spine, going through their throwing mechanics without the throw, essentially. You want to assess their throwing mechanics and energy transfer throughout the kinetic chain. And very commonly seen impairments, I can't stress this enough, is loss of horizontal adduction and internal rotation at the glenohumeral joint. They also could have loss in external rotation. And if they have both internal and external rotation loss, we would consider this a loss in their total arc of motion. They also have posterior shoulder tightness. They have posterior or inferior joint capsule tightness. And then the big area where they might also have tightness is what we refer to as the conjoint tendon. And this is the area of the shoulder where the latissimus dorsi, the subscapularis, and the pec major all go in and insert onto the humerus. And we know that that occurs near the lesser tubercle. So this area can become very tight. And all these muscles, as you know, they perform shoulder adduction. They also perform shoulder internal rotation. So in order to get your arm up to the 90-90 position, you need to be able to have good flexibility and mobility in these muscles, because if we think about going to the 90-90 position, that's shoulder abduction at 90 and also shoulder external rotation. So if the lat, the subscap, and the pec are all tight, they're going to limit you from going into that position. So we spend a lot of time working soft tissue mobilization here, and things like instrument-assisted soft tissue. We'll do dry needling in these areas, etc. And then as far as strength goes, you want the external rotation strength to internal rotation strength ratio to be greater than 66% using a handheld dynamometer. A dynamometer is a device that basically tests strength output. So essentially what we're saying here is these athletes are going to have amazing internal rotation strength, which is likely due to just the repetitive nature of throwing or swimming or whatever, right? The lats, the subscap, and the pec get super tight. So those tight muscles are usually strong muscles. And then you have your stretched, weakened external rotators or periscapular muscles. So we want to make sure that the external rotation strength is within 66% of the internal rotation strength. And this is also seen in Dr. Shanley and Dr. Thigpen's article on Little League elbow. You can pause it here and look through this. We will field any questions you have on this, but this is just a general phase and progression of rehab for someone with a medial elbow injury. That can include also a non-operative UCL sprain, as well as our Little League elbow. So now let's get into the radial collateral ligament sprains, or the LCL sprains. And this usually causes what we would call posterolateral rotary instability. So that's also termed PLRI, posterolateral rotary instability. Background information here: this results from insufficiency of the lateral soft tissue support of the elbow. Significant injury creates posterolateral rotary instability. The mechanism of injury typically involves a combination of axial loading, external rotation, or in this case what we would call that supination, and valgus force applied to the elbow. This causes a dramatic and even traumatic dislocation. And it's typically seen in things like football, Olympic weightlifting, landing from a height and falling onto your arm, outstretched arm. If you notice this bone diagram on the bottom, figure 1A is obviously a normal elbow congruency, but as the elbow is supinated, you can see how that it also glides posterior and may shift out the back end of the capitulum there if there's an axial load through it. The patient history, signs, and symptoms: they may present with a spectrum of impairments ranging from vague symptoms in the elbow to all the way to frank recurrent posterolateral dislocation. They'll complain of lateral elbow pain, clicking, popping, and snapping. Symptoms are often brought on by activities such as pushing up from a chair, that's a key phrase there, or doing press-ups, which place the elbow in an unstable position of external rotation of the forearm, aka supination, with valgus and axial loading of the elbow. Essentially the exact mechanism of injury. A previous history of trauma or surgery on the lateral side of the elbow should be sought. Figure 4 at the bottom also goes over basically the three types of posterolateral rotary instability. And if we looked at the picture marked 0 or reduced just means that the joint is congruent and normal. Posterolateral rotary instability, you can see how the radial head is beginning to supinate, and there's axial compression and also a valgus load. You can see the arrows pointing at the bottom there, which then forces the radial head to kind of get pushed off of the capitulum. And then number 2, you can see that now the ulna has become perched or subluxed. It's not fully dislocated, but the radial head is. And then, of course, picture 3 is the worst, where the radius and the ulna are dislocated. That's bad news. So here are pictures of traumatic dislocations, and if we go through the pictures, top left to bottom right, you'll see our boy Danny Amendola. Bad situation for him. I guess he was trying to plant his arm to stay up, and we see what happens. Rajon Rondo, another guy falling from a height, does not look good. I mean, this is like obvious deformity here. And you got this soccer player who, unfortunately, I think is just in a bad situation, a wrong place, wrong time. He's going for a ball. It looks like he's being tackled, of course. But if you notice, the defender's knee is almost pushing his elbow into that valgus position. And then I think the defender's other arm is coming around and providing a axial load through there. So if we pause this picture, it kind of looks like he's trying to do that, like an MMA fight, but I'm sure this happened in such quickness that it's just the wrong place, the wrong time for that guy in the light blue. And then what do we say about the picture on the right? I mean, that's like 400 pounds. This guy was trying to probably clean and jerk or snatch, and the elbow just gave out on him. There's no stability, and this could also be a UCL injury, but traumatic dislocation is the key. So treatments, what do we do? Conservative treatment, we want to manage chronic posterolateral rotary instability of the elbow, and this depends on the severity of the patient's symptoms. We want to avoid provocative maneuvers, and we might brace to limit supination and valgus loading, but in significantly affected patients, surgery is preferred just because there's no stability. The patient's daily life is very impaired. So surgical treatment aims at retensioning or reconstruction of the lateral ligament complex and correcting any varus deformity of the humerus by an osteotomy, which is where they take a wedge out of bone to reposition it and try to improve alignment. In LCL complex reconstruction, we'll go over this now. The current techniques repair the part of the lateral ligament complex which passes from the lateral humeral epicondyle to the supinator crest of the ulna. A tendon graft is used with fixation achieved by bone tunnels, anchor sutures, or interference screws. And although an autograft of the palmaris longus is commonly employed, you can also use the triceps fascia, semitendinosus, gracilis, plantaris, Achilles tendon, or there are some synthetic devices can be used to create a graft and help reconstruct the LCL complex. So what does that look like? If we look at the picture on the left here, you can see the anterior joint capsule, the annular ligament, which is part of this lateral collateral ligament complex, and then the LCL, which is made up of the radial collateral ligament and the lateral ulnar collateral ligament. You look on the picture of the right. So the picture on the left depicts just normal anatomy, and the picture on the right depicts how they would reconstruct this, and we've highlighted this in red. You can see the lateral epicondyle there's been holes drilled into it, as well as the lateral portion of the ulna, and a tendon graft has been weaved through to provide lateral elbow stability. The anterior capsule and the posterior capsule of the elbow has been plicated and sutured to provide capsular stability as well. Here you can pause it. This is looking at a post-op repair or reconstruction protocol for LCL reconstruction. The goal of this class is not to go into depth regarding the protocols, but I do want you to get an idea, based on normal healing times and things of that nature, what activities may be appropriate at what time during rehabilitation. And I believe this is our last medical diagnoses for this Part 1 series, so hang with me. We have posterior elbow impingement. This results from repetitive posterior abutment of bone and soft tissues in the posterior compartment of the elbow. Soft tissue inflammation and osteophyte formation occurs, worsening the mechanical symptoms. Mechanism of injury: repetitive, excessive, forceful terminal elbow extension. Athletes at risk include throwers, martial arts, and weightlifters. Anything that involves forceful terminal elbow extension, such as releasing a ball at full elbow extension or punching someone in the face, like in a martial artist. Patient history, signs, and symptoms include pain in the posterior elbow, which increases with passive overpressure into hyperextension. If symptoms have progressed, patient may have an inability to fully straighten the elbow due to stiffness, pain, or increased bony abutment, aka osteophyte formation. Think here of Wolff's Law. We also see this condition in patients who are UCL deficient, and that's because the medial elbow instability may lead to increased compressive forces in the posterior elbow upon ball release or upon terminal elbow extension, then leading to things such as osteophyte formation and soft tissue impingement. If we look onto a radiograph here on the right, it's one way to diagnose it. You can see the osteophyte coming off of the proximal end of the olecranon there. Conservative treatment includes physical therapy. It typically has good results if the aggravating activities are stopped and patient is compliant with the treatment plan. We can also do soft tissue mobilization to the triceps and the triceps fascia, and anything we can do to reduce inflammation in this area. Surgical treatment is considered if conservative treatment fails. They would go and do an arthroscopy for osteophyte removal. I want to thank you guys for your patience. We will now go into part 2 of the elbow differential diagnosis. Thank you.